Welcome to the OncoSec training video for the PISCES study. This educational video is a step-by-step guide outlining the preparation of tavokinogene telsoplasmid, also known as Tavo, and administration via electroporation.
Clinical trials are designed to answer specific research questions and offer patients access to new and novel treatments. PISCES is a phase 2 study of intratumoral PIL-12 EP plus IV pembrolizumab in patients with a pathological diagnosis of unresectable or metastatic melanoma who are progressing or have progressed on pembrolizumab or nivolumab. This training video will provide instructions regarding the preparation and administration of tavokinogene and EP. The video is divided into 3 sections. In this section, we will review the process for the plasmid preparation. During the second section, we will discuss the electroporation device and setup. In the third and last section of the video, we will walk through the administration process. But first, let's start with a quick overview of Tavo and electroporation.
What we know about IL-12 that's a little bit different than other pro-inflammatory, pro-survival cytokines such as IL-2, for example, is that IL-12 has an effect early on the immune system. And this is particularly important when thinking about how it applies to OncoSec's platform. IL-12 works in the tumor by coordinating 2 arms of the immune response. That is the adaptive as well as the innate side. So early on, at an early time point, the innate side plays a critical role in that predominantly NK cells are acting quickly. And there is certainly an anti-tumor response to that, a tumoral static side, but importantly, it transforms the tumor microenvironment by producing interferon gamma, which in concert with the IL-12 creates this feed-forward loop. And that does a lot of things, but one of the critical things that it does is supports a particular type of antigen-presenting cell known as CDC1s. And these we know to be critical to drive the adaptive side of the immune response, and that is specifically priming naive CD4 and CD8 T cells. What sets OncoSec's intratumoral electroporation of IL-12 apart from other cytokines that are delivered in a systemic fashion is that we are able to trigger an early event in the tumor where the antigens and the milieu is so critical. So we see that polarization towards type 1 happens early and allows for an effective priming. That is different than cytokines that are delivered systemically and may support more of, say, an effector arm. That happens later on in terms of immunological time. We've learned from comparing our monotherapy studies to the studies where our IL-12 therapy has been combined with pembrolizumab, that's the anti-PD-1 checkpoint inhibitor therapy, is that we see our therapy drives that strong immune response that I described earlier. But what happens is part of the compensatory mechanism that goes hand in hand with that immune response is really what we call the adaptive immune resistance. And so the adaptive resistance allows for the tumor, the stromal, and even in sort of some of the tumor-associated immune cells to upregulate PD-L1. And this is critical because it starts to shut down that immune response and sort of limits some of the impact from the primed and effector CD8 positive tumor-infiltrating lymphocytes that are in the tumor and they're doing their job, but they're getting blunted through this axis. That's the PD-L1, PD-1 axis. And our monotherapy does a great job of really driving that interferon gamma IL-12 feed-forward loop that I described. And part of that, again, is driving expression of PD-L1, which then can shut down that immune response. So this therapy really naturally synergizes with the checkpoint inhibitors so that we now see more of that PD-L1 in the tumor microenvironment, which effectively creates a substrate for these checkpoint inhibitors. So now we have the T cells there, PD-L1 is upregulated, and those antibodies can come in and effectively block that inhibitory axis.
The Tavo plasmid is drawn into a syringe and injected into the tumor. Next, the sterile applicator of the electroporation device is inserted into the tumor at the site of Tavo administration and the pulse applied to electroporate the cells. This process enables the uptake of Tavo into the cell. Inside the cell, the Tavo is transcribed by the cell, and the cytokine IL-12 is produced. IL-12 is a pro-inflammatory molecule that stimulates a local immunological response inside the tumor. This local response then becomes a systemic immune response, attacking cancer throughout the body.
Basically, what you do is that if you have a lesion on your skin, you basically inject the plasmid a few seconds before you do the electroporation. And you could use just a simple syringe and needle, and the plasmid is injected directly into the lesion itself. And once that's done, you basically put the electrode, which sits right over the lesion, and then you numb the lesion, the skin around the lesion using lidocaine, put the needles in, and then a lot of times I'll hold the lesion up just to isolate the skin, and then you push a foot pedal, and that basically sends an electric shock into the lesion, and then that's basically it. A couple of seconds later, you're done.
As you can imagine, for this treatment, accurate tumor measurements are essential for calculating the Tavo dose. Let's review how to perform the tumor measurements.
Clinical tumor measurements should be performed when the patient is in the clinic. Using measuring tape or a ruler, measure the longest diameter and longest perpendicular diameter. As the PI measures the tumor, the clinical research coordinator or nurse records measurements on the tumor assessment log. All accessible target lesions, as well as any other lesions that will be treated using electroporation, should be photographed and measured. Each lesion should also be numbered and labeled. Clinical tumor measurements can be performed by photographs as well. All lesions should be photographed. One picture should be taken from the distance of 6 inches, and a second picture of the same lesion from 18 inches. Lesions being tracked and measured on CT scans should also be recorded on the tumor measurement log. Plasmid volume calculations and requests need to be completed for each lesion that is to be treated. For each lesion, include the lesion number, the body site of the lesion, and the tumor measurements. Then, calculate the plasmid volume using the formula A times B squared divided by 8, where A is equal to the longest diameter and B is equal to the longest perpendicular diameter. Although unidirectional measurements will be used for RECIST evaluation, bidirectional measurements are required for dosing calculation. The calculation should be verified by the CRC or pharmacist prior to preparing the plasmid for injection. Different pharmacies may have different processes for submitting the drug requests. They may create their own request forms or have an electronic system where all drug requests will be submitted by the PI. On the day of treatment, the pharmacist or study coordinator will verify the plasmid calculations and remove the required number of vials from the freezer and document traceability. The vials should be placed on the countertop to thaw. This takes approximately 15 minutes. Once the plasmid is completely thawed, invert the vial several times to ensure proper mixing. Select the appropriate syringe based on the plasmid volume and draw up, using sterile procedure, the required volume into the syringe. The plasmid is stable at room temperature but must be used within 8 hours of preparation. Once the patient has arrived, the plasmid can be placed in a gel pack and cloth for transfer to the treatment room. The study coordinator will deliver the syringes to the patient treatment room. Any items that will be used for patient treatment should be set up by the nurse or study coordinator. Pain-relieving medications such as lidocaine and EMLA cream may be used. Ice can also be used prior to treatment. Additionally, gauze, sterile gloves, and iodine, or whatever's being used for sterilization of the treatment area, should be available for the investigator.
This concludes this section of the training video. In the next installment, we will review the procedure for setting up the OMS electroporation device.